Hemodynamic monitoring equipment. 5 basic components make up the hemodynamic monitoring system. 1 is an indwelling intravascular catheter. 2 is a pressure transducer to amplify the signal accurately. 3 is a cable to transmit the signal to the monitor. 4 is a bedside monitor, and 5 is a pressure bag and tubing with a flush device and solution. The chapter discusses the equipment and the setting up, leveling, zeroing, and troubleshooting procedures. What is a pulmonary artery catheter? The type of hemodynamic monitoring needed determines the catheter type and placement. The pulmonary artery PA catheter is a flexible, hollow catheter with multiple ports and corresponding lumens. The catheter is 100 centimeters long from the tip. Every 10 centimeters are marked with a black line to allow for estimating the catheter's location upon insertion. Need to know? Currently, several types of PA catheters are available with various features and varying numbers of lumen. A pulmonary artery catheter may have 4 or 5 lumens. So you have the distal opening, the thermistor opening. This is the proximal opening. And then you have the distal port, the balloon inflation port, thermistor connector, proximal port. A 4-lumen catheter has the following: a proximal injectate port for monitoring right atrial pressures. 2 is a pulmonary arterial distal port for measuring pulmonary artery systolic, diastolic, and mean pressures. 3. Balloon inflation port to allow for inflation of the balloon at the distal tip of the catheter for the purpose of flotation during insertion and obtaining PA occlusion pressures, also known as pulmonary capillary wedge pressures or pulmonary artery occlusion pressures. A 4-lumen catheter also has a thermistor wire connector used for connecting to a cable for measuring cardiac output and blood temperature. The 5-lumen PA catheter contains an additional lumen called the proximal infusion port. The opening to this port is located in the right atrium, just proximal to the opening of the right atrial. Central venous pressure (CVP) port. The opening to this port is located in the right atrium. Just proximal to the opening for the right atrial CVP port. Other types of PA catheters may contain an additional lumen for the dual purpose of inserting a pacemaker electrode into the right ventricle or fluid infusion. Some catheters are equipped with fiber optic wires providing the ability to measure mixed venous oxygen saturation, SVO2. Other types of catheter provide continuous cardiac output monitoring. Take-home points. For patients with septal defects, inflate the balloon with carbon dioxide. If the balloon ruptures, carbon dioxide is readily absorbed and minimizes the risk of air embolism. The balloon is inflated with air or carbon dioxide, but never with fluids. The balloon should be filled with the minimal amount of air or carbon dioxide required for the process of obtaining the pulmonary artery occlusion pressure or the pulmonary capillary wedge pressure. Catheter manufacturers have recommended guidelines for the maximum amount of air per balloon inflation. Never exceed the manufacturer's recommendations, which is usually 1.5 milliliters of air. Overinflation may result in balloon rupture or too much pressure on the pulmonary artery, causing the pulmonary artery to rupture. Pulmonary artery rupture is a medical emergency. Indications for pulmonary artery catheter monitoring. The pulmonary artery catheter helps differentiate causes of fluid status alteration, particularly when the heart or kidneys are not functioning properly. Monitoring pulmonary artery pressures helps in assessing left ventricular function. It also helps in determining potential causes when right-sided and left-sided pressures do not correlate with expected values. Pressures monitored with a pulmonary artery catheter. PA catheters allow for monitoring the PA systolic, diastolic, and mean pressures. The catheter can also monitor right atrial pressure, CVP, and pulmonary capillary wedge pressure, also called PAOP, occlusion pressure, which reflects left ventricular and diastolic pressure. In addition, cardiac output, vascular resistance, systemic and pulmonary, and mixed SVO2 can be monitored. CVP measurements can be directly measured by several different methods. If a PA catheter is inserted, the right atrial port, proximal injectate port, can be used for monitoring right atrial pressures, CVP. Another method of measuring CVP is by placing a central line in the inferior vena cava, superior vena cava, or right atrium. When using a central venous catheter to measure pressures, the distal port must be used, which more closely approximates the location of the CVP lumen of the PA catheter. What you do: catheter insertion. The physician, using sterile technique, inserts the PA catheter. The PA catheter can be percutaneously inserted or by a cut-down approach. Waveform analysis can identify catheter location, Therefore, fluoroscopy is not usually used. Hemodynamic pressures are affected by the position of the catheter tip and blood flow. Appropriate catheter length and position are essential in producing waveforms representative of the patient's pressures. Take-home points. The proximal infusion port is used for infusing medications and intravenous IV solutions. This port is not used for monitoring pressures. CVP is the main pressure of all the venous return pulled from the body as it enters the right atrium. Because no valves exist between the vena cava and the heart, the right atrial pressure is reflective of the CVP. The CVP reflects right ventricular end diastolic pressure for assessing right ventricular function and general fluid status. PA catheters do not allow for blood pressure monitoring. To monitor arterial pressures, a catheter must be placed in an artery. A PA catheter is inserted into a vein and guided through the heart and into the PA. The pulmonary artery catheter is used to determine hemodynamic status in critically ill patients. It provides information about right and left-sided intracardiac pressures and cardiac output. It also guides therapeutic interventions related to fluid status and vasoactive drug therapy. The first image shows a pressure below 10, so like 8 millimeters of mercury, when the catheter enters the right atrium through the vena or superior vena cava. Then when it enters into the ventricles through the atrioventricular through the tricuspid valve. Through the tricuspid valve, the pressure drops even lower below 5. And this is systole. And this is the waveform that is produced on the graph. And this is the dichordic valve closing. What? I think it's the dichordic valve closing. I don't know. And then when the catheter enters the pulmonary artery through the pulmonic valves, the pressures increase above 10. It's like 12 mercury. And the final image shows when it's within the pulmonary artery, finally inside the pulmonary artery. And that's when you get your pulmonary wedge pressures, and it's below 10. Once measured, or once inserted, the catheter is progressed and the balloon is inflated, causing the catheter to drift with the flow of blood from the right atrium to the right ventricle through the pulmonic valve into the pulmonary artery. When the catheter is inserted without fluoroscopy, observing the waveform identifies the location of the catheter. So if you see a waveform with a peak pressures of 10, and it's like that, then you know that the catheter is in the right atrium. If you see a waveform that has a peak with a dichrotic notch, that's the ventricles. That's the right ventricle. If there's one with a regular size hump and a smaller hump next to it, it might be N. It might be in the pulmonary artery or passing through the valves. And when it's all the way into the pulmonary artery, the waveforms would look like that, with no peak because of the occlusion. Okay. The most common insertion sites include one of the following veins: subclavian, internal jugular, femoral, and sometimes brachial. Okay, so the most common insertion sites include one of the following veins: subclavian, internal jugular, femoral, and sometimes brachial. Catheter or equipment-related problems. Because pulmonary artery catheters are inserted into the venous system and are directed with the flow of blood, catheter whip can occur. It's also called catheter noise or catheter fling. This movement of the catheter during the contraction of the right ventricle causes an artifact to be superimposed on the waveform. Artifact is a type of arrhythmia that would show up on the EKG. Adding a high-frequency filter to the monitoring system can eliminate catheter whip. If no filter is used, correct and consistent waveform measurement is imperative. Refer to institutional policy for frequency and protocols regarding waveform measurement. Potential complications of a pulmonary artery catheter may include ventricular ectopy, pulmonary artery infarction or rupture, air emboli, infection, and sepsis. So that's a good point to remember. Pulmonary hypertension and advanced age and factors that can predispose a patient to pulmonary artery rupture when a pulmonary artery catheter is placed. So what monitors the right atrial pressures and is used for cardiac injectate fluid? Is it the PA distal port, the proximal injectate port, the thermistor, the balloon inflation port? It's the proximal injectate port. So the proximal injectate port monitors right atrial pressures and is used for cardiac output injectate fluid. What is used for obtaining cardiac output measurements and for measuring blood temperature? That has to be the thermistor. What allows for inflation of the balloon? The balloon inflation port. And what monitors the pulmonary artery systolic, diastolic, and mean pressures? The pulmonary artery distal port. So which of the following are true or false? CVP can directly measure. CVP can be directly measured by several different means. Is that true or false? That is true. Because on page 3 it says CVP measurements can be directly measured by several different methods. If a PA catheter is inserted, the right atrial port can be used for monitoring right atrial pressures. Another method of measuring CVP is by placing a central line in the inferior vena cava, superior vena cava, or right atrium. Okay, so number 6, CVP is the mean pressure for the left ventricle. That is false. CVP is the mean pressure for the right ventricle. No. CVP is right atrial pressures. I thought it was central venous pressures, but yeah, it's the central venous pressure of the right atrium. CVP reflects right ventricular end diastolic pressure. That is true. What is an intra-arterial catheter? An intra-arterial catheter is a short catheter, usually less than 4 inches, that is commonly inserted into the radial artery, although other insertion sites such as the brachial, femoral, axillary, or pedal arteries may be used. So 4 inches pointer call. Need to know. Invasive arterial monitoring allows for the direct measurement of systolic, diastolic, and mean blood pressure levels. Direct blood pressure monitoring is more accurate than indirect, non-invasive monitoring, especially during conditions altered peripheral resistance, abnormal body temperature, or abnormal blood flow. So that's a good listing question. So direct blood pressure monitoring is considered more accurate than indirect, non-invasive monitoring, especially during which conditions? And the answer could be conditions of altered peripheral resistance, abnormal body temperature, or how is this done? You should gather the equipment, set up the pressure tubing and transducer system, and fill the pressure bag and inflating it with 300 millimeters of mercury. That's a good point. Much millimeters of mercury is used to fill the bag or inflate the bag. Turn on the monitoring system for inserting the catheter. Position with insertion per institutional protocols using sterile technique. Once the catheter is inserted, attach the catheter to the high-pressure tubing of the transducer system. Once the catheter, just write that. Set the scales on the monitor to a range higher than pressure. Ensure the arterial waveform will be the appropriate size. Accurate arterial pressures, usually in range. The scale range must be arterial pressures, or the waveforms will be damping, lead to inappropriate treatments. Follow the procedure for leveling and zeroing the system. Take-home points. MAP, pressure in the peripheral arterial system during systole and diastole. It estimates perfusion pressure in the major arteries. Differences in arterial pressure measurements can occur from the peripheral and central positions. As the distance from the aortic valve increases, the systolic pressure increases. However, the mean blood pressure decreases. So that is a good point to recall. Before a radial arterial line is placed, an Allen's test should be performed. This test is used to detect appropriate collateral circulation in the ulnar artery. However, it is not an accurate predictor of hand ischemia. So that's another good point to recall. Which test is performed before placing an arterial line? Radially, and the answer is Allen's test. The 6 basic components of hemodynamic monitoring system. So we have the indwelling IV catheter, the pressure transducer, the monitoring cable, bedside monitor, the pressure bag with the tubing, the flush device, and the solution. So that's a good question too. Pulmonary artery catheter helps differentiate causes of fluid status alterations and a hemodynamic value. Pulmonary artery catheters allow for monitoring of the PA, systolic, diastolic, and mean pressures. A pulmonary artery PCWP reflects left ventricular end diastolic pressures, PA catheters do not allow for blood pressure monitoring because it's occluding the heart, the blood flow to the heart. What is the equipment needed for hemodynamic monitoring? The equipment required for hemodynamic monitoring includes the catheter, tubing, transducer, cable, and monitor. That was just the question from earlier. The catheter, tubing, and transducer system should be as direct and short as possible. From the catheter to the transducer should be stiff and non-compliant to reflect accurate pressures from the patient. Any air bubbles should be evacuated from the tubing during setup. Stopcocks and tubing connections should be initially tightened and monitored for loose connections or fluid leaks. Need to know. Transducers are devices that measure pressure, flow, temperature, light intensity, and sound. The transducer converts the physiologic event into an electrical waveform. This waveform is transmitted to the monitor through a cable. A bedside monitor is an instrument used to display and record the physiological events. Most frequently, bedside monitors reflect hemodynamic pressures as a waveform and a digital display. Any invasive intravascular monitoring catheter should be attached to a system that has a flush solution, usually either heparinized or non-heparinized normal saline, under pressure through an inflatable pressure bag. The system should also have a rigid, non-compliant pressure tubing with a transducer and flush device that controls the flow of solution through the system. What you do? The transducer used for monitoring pressures must be leveled and zero referenced to obtain reliable measurements. This setup standardizes the equipment. To level a transducer, position the air fluid interface, the stopcock, at the top of the transducer, at the level of the patient's right atrium. This position is referred to as the plebostatic axis and is located at the fourth intercostal space, mid-axillary position. So that's a good point to recall. To level a transducer, position the air fluid interface at the level of the patient's right atrium. This position is referred to as the plebostatic axis and is located at the fourth intercostal space, mid-axillary position. Okay. Leveling the transducer. Once the equipment is assembled and the monitor is turned on, the transducer needs to be leveled. Leveling the transducer is the process of referencing the tip of the intravascular catheter horizontally to a specific position on the transducer, usually at the top or side stopcock of the transducer. This leveling allows the transducer to be opened to air to a zero reference position. What the transducer is mounted on When the transducer is mounted on a pole in a transducer holder, the transducer holder can be adjusted to ensure that the stopcock height is level with the tip of the intravascular catheter, usually at the plebiostatic axis. Leveling can be accomplished with a carpenter's level. Leveling should be repeated when the position of the patient or the height of the bed is altered. Zeroing the transducer. Distortion in the transducer must be compensated for electronically. This process is referred to as zeroing the transducer. The process of zeroing should be performed after the catheter is initially inserted, but before the first pressure measurements are obtained. Institutional protocols regarding frequency of zeroing should be followed. However, the transducer should be zeroed after any intervention that alters the patient's position, after any repositioning of the patient, or at least once during a shift. To zero the transducer, you should open the stopcock on the transducer to air and close it to the patient. Depress the automatic zero button on the monitor. The digital readouts on the monitor should display zero. Close the stopcock to air and open to the patient once the zero reference is obtained. Fast flush the system. Do not rely on pressure waveforms and digital displays unless the system is accurately assembled with tightened connections, zero balanced, leveled, and calibrated. If any question of inaccuracies of waveforms or trends remains, investigate any possible patient or equipment causes before instituting medical or pharmacologic interventions. The position of the transducer will affect the pressure readings. If the transducer is too low, it will artificially increase the pressure readings. Having the transducer too high will artificially decrease the pressure readings, which may lead to incorrect treatment for the patient. The specifics of a pulmonary artery and arterial line setups vary among institutions. Follow individual institutional protocols and equipment lists. The following is a list of potential equipment: IV pole and transducer holder. The transducer may be inserted in the holder or placed on the patient's chest at the plebostatic axis. A bag of flush solution, often heparinized or non-heparinized saline, per institutional protocol. Transducer cables for single, double, or triple line setup. One single, double, triple disposable invasive pressure monitoring kit. Tubing, transducers, and flush device. Pressure bag, hemodynamic bedside monitor, small sterile cup or bowl of sterile saline to test balloon integrity. Preparation for hemodynamic monitoring. You should gather the equipment for line setup and PA catheter insertion per institutional protocols. Turn on monitoring system before catheter insertion. Explain the procedure to the patient. Explain all consent forms Ensure all consent forms are signed. Have emergency equipment available. Attach the transducer holder to the pole. Slide all transducers into the holder. Tighten connections along pressure bag. I'm so distracted. Slide all transducers into the holder. Tighten connections along pressure tubing. Spike bag of flush solution with IV spike portion of pressure tubing set, and insert flush solution into pressure bag. Flush each line. To tip off pressure tubing into each stopcock port. Apply 300 mmHg pressure to pressure bag. Inspect tubing, transducers, and stopcocks for air bubbles and remove any if present. Replace any vented caps on stopcocks with non-vented dead end caps. Recap distal end of pressure tubing until ready to connect to catheter and patient. Ensure transducer cable is connected to monitor. set the scales on the monitor to the 0 to 40 range to reflect pressures accurately. Follow the procedure for leveling and zeroing the system. Oh my god. Alright. Okay, I'm gonna skip the preparation for catheter insertion. Okay. So what converts a physiologic event into an electronic display? That would be a transducer. What displays and records events? That would be the monitor. What is essential for obtaining reliable measurements? Leveling and zeroing. And what's found in the fourth intercostal space mid-axillary line? The plebostatic axis. B. It's not used for any of those answers. Okay. What is a square wave test? The square wave test is a procedure used to test the dynamic response of the fluid-filled monitoring system to reproduce the patient's pressure accurately on the monitor. This calibration is performed on all hemodynamic systems before assuming that the pressures and waveforms are accurate. Dynamic response testing, the square wave test, can identify whether the system accurately reflects the pressures and waveforms from the patient. An optimal system produces an accurate square wave test, which consists of 1 to 2 oscillations and then a return to a normal waveform. If the system has extraneous resistance, the upstroke of the square wave will slur and less than 1 to 2 oscillations will be observed before returning to the patient's waveform. This represents an overdamped system, which will cause the patient's waveform to display a falsely decreased systolic pressure. So that is a good question. That is a good point to recall. Pretty much what is an overdamped system? Give the answer for that. So this is what the accurate square test should look like. See the observed waveforms. Let me read this part over. So what is a square wave test? The square wave test is a procedure used to test the dynamic response of the fluid-filled monitoring system to reproduce the patient's pressure accurately on the monitor. This calibration is performed on all hemodynamic systems before assuming that the pressures and waveforms are accurate. Dynamic response testing can identify whether the system accurately reflects the pressures and waveforms from the patient. An optimal system produces an accurate square wave test, which consists of 1 to 2 oscillations and then a return to a normal waveform. If the system has extraneous resistance, the upstroke of the square wave will slur and less than 1 to 2 oscillations will be observed before returning to the patient's waveform. This represents an overdamped system, which will cause the patient's waveform to display a falsely decreased systolic pressure. So it's overdamped here. So the upstroke is slurred. That's shown as slurred. In addition, the waveform tracing may be diminished with poorly defined components. If the waveform tracing has extra oscillations, more than 2, before returning to the baseline after the fast flush, the monitor may falsely display elevated systolic pressures and potentially low diastolic pressures, which is referred to as an underdamped system. So what you would do, you would pull or squeeze the fast flush device connected to the transducer tubing for at least 1 second and release rapidly. So you just basically pull down on it. Just pull, pull, pull until it flushes the system. The waveform tracing should have a rapid rise with a squared pattern to the top of the graph paper. Once the flush device is released, 1 to 2 narrow oscillations should be observed before the normal pressure waveforms return. This procedure shows whether the damping characteristics of the system, loss of the energy or vibrations from the monitoring system caused by internal resistance, accurately reflect digital readouts and pressure waveforms. The square wave test should be repeated when waveform accuracy is in question. Interventions for an overdamped system includes checking the tubing and system for blood clots, air bubbles, or blood left in the tubing after blood sampling. Ensuring that the tubing from the transducer to the patient is rigid and as short as possible, and that all connections are secure. Ensuring that no kinks in the tubing can be found. Interventions for an underdamped system include ensuring that all air bubbles, including pinpoint bubbles, have been removed from the system and that large bore short tubing is being used. The square wave test can identify whether the system accurately reflects the pressure and waveforms from the patient. True or false? True. Slurring of the upstroke of the square wave represents underdamping. false. Slurring represents overdamping. An underdamped system can falsely elevate systolic pressures. True, underdamped system increases falsely systolic readings. What is the importance of patient positioning? Correct patient positioning is important in obtaining accurate pressure measurements. Patients are often placed in a supine position, that means laying on their back. However, situations exist in which the patient is unable to tolerate lying flat. If the hemodynamics system has been properly leveled and zeroed, then the patient may be placed in a backrest position of 0 to 60 degrees without a significant change in the pulmonary arterial pressure or wedge pressure measurements. Need to know. When position changes are made, the transducer should be leveled and the change in position documented on the hemodynamic flow sheet. For accuracy, once position changes are made, allow 5 minutes before obtaining pressure measurements. Consistency is the important factor in positioning. Patient positioning for measuring pressures has been the subject of many research studies that support the belief that backrest positions up to 60 degrees have little effect on the variability of hemodynamic measurements as long as the plebostatic axis and appropriate leveling have been accomplished. What you do? When monitoring right atrial pressures, the nurse should ensure the patient is supine and flat, or with the head of the bed elevated up to 60 degrees. Research has shown that measures taken with a patient in a side-lying position may reflect distorted values because of a change in intrathoracic pressures. The best position is supine and within the 0 to 60 degree range. Okay, so when the patient position changes, the transducer should be what? It should be leveled with the plebostatic axis. Patient backrest positions up to blank degrees have little effect on variability of hemodynamic measurements as long as the blank and leveling has been established. Up to 60 degrees, as long as the plebostatic axis and leveling has been established, then no effect on variability of hemodynamic measurements will be seen. What is the importance of identifying monitoring problems? Pressure measurements and waveforms should correlate with the patient's clinical picture. Technical problems with the monitoring system may result in distorted waveforms, inaccurate pressure measurements, or inability to obtain a waveform in pressure. Many therapeutic treatments are based on the values obtained with the PA catheter. If there is a systemic problem, then inappropriate treatments may be initiated with potential deleterious, with potential deleterious effects to the patient. Need to know troubleshooting. Troubleshooting potential monitoring problems includes following the system for the patient to the monitor. So you just trace it. Following the system, so you start at the patient where the patient is Whichever artery the patient's connected, you start there and you trace the wires up to the monitor and look for any kinks or ear bubble, or any other problems that need to be fixed. So troubleshooting 101, following the system from the patient to the monitor, not from the monitor to the patient. Ensure correct, consistent patient positioning, a leveled transducer that has been zeroed or re-zeroed, and an intact tubing and a flush system without air bubbles or loose connections. Also check the pressure bag for adequate inflation pressure. If no visible clues are observed in the tubing system, consider the potential for problems within the catheter or related to catheter position. So if a balloon ruptures suspected, never continue to attempt balloon inflation. Label the balloon port as unusable and notify the physician. Follow institutional and unit protocols for further interventions. Spontaneous catheter wedging can result in pulmonary artery necrosis or rupture. Following institutional protocols, slowly withdraw the catheter until a normal pulmonary artery waveform appears. A catheter should only be wedged for 2 to 3 respiratory cycles to avoid damage to the vessels. So that is a good note to recall. The catheter should only be wedged for 2 to 3 respiratory cycles to avoid damage to the vessels. If wedge waveform is observed, it is urgent that this be corrected immediately. Never forcibly irrigate the catheter. This may dislodge the obstructing clot and result in embolization. 3 potential system problems that may be encountered with a pulmonary artery monitoring system: inability to obtain wedge pressures, dampened pulmonary artery waveforms, or no waveforms at all. So, how would you troubleshoot the inability to obtain a wedge pressure? The potential cause of that would be that the balloon has ruptured or the catheter has migrated backwards. Solutions to the inability to obtain a wedge pressure is to observe waveform for confirmation of catheter position, notify the physician, obtain a chest x-ray per protocol to confirm catheter position, and you follow the hospital policy. For dampened waveforms, potential cause could be air observed in the tubing, blood has clotted within the catheter or at the tip, catheter has kinks or knots, loose tubing connections are observed, catheter has spontaneously migrated forward, inappropriate monitor scales have been selected. Example, if a pulmonary pressure is measured using arterial pressure scale, and the waveform would be damped. Or another cause of a dampened waveform could be that the transducer is cracked. Solutions for dampened waveforms: you inspect the tubing for air or blood. Air in the system should be evacuated before reaching the catheter. Ensure pressure bag is fully inflated. Obtain a chest x-ray per hospital protocol. Ensure the connections are tightened. This is an emergency if a dampened waveform shows up, so you should notify the physician immediately and follow hospital protocols for pulling the catheter back. Change monitor scales to the appropriate settings for a hemodynamic value being monitored. And also inspect the transducer in case it's cracked, or change the entire transducer system. If you get no waveform at all, possible cause could be that the monitor is turned off, stopcocks are turned off to the patient, so it's not reading what the patient's doing. The transducer could be defective, the monitor or system has been incorrectly set up, pressure cable is defective, or the catheter tip is clotted. Solutions: you change the transducer system, you check system for patient to monitor, ensure correct cable connection, correct line setup, appropriate scales, check the stopcock is turned onto the patient in the transducer, turn off to side port, check the on and off switch, change the cables, notify the physician, and clotted catheter requires catheter replacement. Okay, so that's the end of that.